10 case-based questions on pneumonia. Case 1. A 32-year-old male presents with a 4-day history of fever, productive cough with rusty sputum, and pleuritic chest pain. His vitals shows a temperature of 38.5 degrees centigrade, respiratory rate of 22 per minute, and blood pressure of 120/75 mm of mercury. Chest X-ray reveals a lobar consolidation in the right lower lobe. Question 1. What is the most likely diagnosis? And what is the first line outpatient treatment? Answer. Diagnosis: community acquired pneumonia, likely Streptococcus pneumoniae. Treatment: amoxicillin 1 gram 3 times daily for 5 to 7 days. The patient's presentation is classic for lobar pneumonia caused by Streptococcus pneumoniae. Outpatient treatment for CAP in a healthy adult without comorbidities is high-dose amoxicillin. Alternatives include doxycycline or a macrolide like azithromycin if there's a penicillin allergy. Question 2. What if the patient had comorbidities like diabetes or chronic heart disease? How would the treatment plan change? Answer. The recommended outpatient treatment would shift to combination therapy, amoxicillin clavulanate plus a macrolide like azithromycin or a fluoroquinolone like levofloxacin. Case 2. A 67-year-old woman with a history of COPD presents with dyspnea, fever, and purulent sputum. Her respiratory rate is 30 per minute. Blood pressure is 100/65 mm of mercury, and she is confused. Chest X-ray shows bilateral infiltrates. CURB 65 score is 3. Question 3. What is the most likely diagnosis and what is the appropriate management? Answer. Diagnosis: severe community acquired pneumonia. Management: admit the patient to the hospital for IV antibiotics. Treatment: ceftriaxone 2 gram IV once daily plus azithromycin 500 mg IV once daily or levofloxacin 750 mg IV once daily. Question 4. What does a CURB 65 score of 3 indicate? Answer. The CURB 65 score helps assess pneumonia severity. A score of 3 suggests a high risk of mortality up to 14% and requires inpatient management. The score includes confusion, urea greater than 7 millimole per liter, respiratory rate greater than or equal to 30 per minute, blood pressure less than 90/60 mm of mercury, and age greater than or equal to 65. Question 5. What additional test should be performed in this patient? Answer. Blood cultures, sputum cultures, and urine antigen test for Legionella and Streptococcus pneumoniae should be ordered. Arterial blood gas may be needed to assess hypoxia. Case 3. A 58-year-old man develops fever, productive cough, and hypoxia 3 days after being intubated in the ICU. Chest X-ray shows new bilateral infiltrates. Question 6. What is the likely diagnosis and what antibiotics should be started? Answer. Diagnosis: hospital-acquired pneumonia. Treatment: empiric broad-spectrum antibiotics, piperacillin tazobactam 4.5 gram IV every 6 hours or meropenem 1 gram IV every 8 hours. Question 7. Why are broad-spectrum antibiotics used initially in HAP? Answer. HAP, especially in ICU patients, often involves multi-drug resistant pathogens like MRSA and Pseudomonas aeruginosa. Broad-spectrum coverage is used until culture results allow for a de-escalation. Question 8. What clinical signs suggest a patient may have MRSA pneumonia? Answer. Risk factors for MRSA include prior antibiotic use, prolonged hospital stay, and presence of skin infections or abscesses. Hemoptysis, cavitary lung lesions, and rapid clinical deterioration also raise suspicion. General pneumonia knowledge questions. Question 9. What is the difference between typical and atypical pneumonia? Answer. Typical pneumonia, example Streptococcus pneumoniae, Haemophilus influenzae, presents with acute onset, high fever and lobar consolidation. Atypical pneumonia, example Mycoplasma, Legionella, tends to cause a more gradual onset, dry cough and patchy infiltrates on X-ray. Question 10. How long is the duration of antibiotic therapy for CAP and HAP? Answer. CAP is typically treated for 5 to 7 days with clinical reassessment after 48 hours. HAP treatment lasts 7 to 14 days depending on patient's response and culture results. Interesting fact. Did you know that atypical pneumonia, often caused by Mycoplasma pneumoniae, is sometimes called as walking pneumonia? Because patients may not appear seriously ill despite significant X-ray findings. That wraps up today's 10 case-based questions on pneumonia. If you haven't seen our previous videos on pneumonia's clinical presentation and pharmacological treatment, check the links in description below. Don't forget to like, share and subscribe to 10 daily medical questions. Have a topic you want us to cover? Let's know in the comments below. See you in the next video.